Dr. Monica Swahn is a professor in the School of Public Health. She's a longtime member of the Partnership for Urban Health Research. She does some very interesting work in Africa, and she's been working in Uganda, so she's going to share her research on youth and some prevention work around alcohol and HIV risk in Uganda. With Dr. Swahn, the next hour is yours.
Well, thank you, John. I appreciate that. So I think they're pretty much all new faces. I don't think I've had any of you in my class. No? I mean, two of my students, Sarah and Malik, are sitting over there, but the rest of you, what track are you on? Is it epi, behavioral? See a couple nods. Environmental? Policy. Anybody outside from public health? Sociology. All right, so we have a great mix in the room.
Biology.
Really? That's fantastic. So glad that you're interested in urban health. As John mentioned, I'm very fortunate to be one of the key Partnership for Urban Health Research faculty members. And so those of us who are part of the partnership tend to do obviously more urban health type research. But I'm going to tell you about one of my favorite projects. And I'm going to share with you a little bit of data, very descriptive data, but this is more about setting up a new project that we have, and it's actually to develop a structural intervention. And when we say structural intervention, we tend to talk about environmental or community-based or policy-type strategies to, in this case, delay alcohol use and also reduce alcohol-related HIV risk among youth who live in the slums of Kampala, Uganda. So before I start, as always, I need to acknowledge that NIH is funding this project, and of course we're very gracious and grateful that they do. So I'm going to talk a little bit about, why are we focused on Uganda? What is the context in Uganda that makes this research relevant there? And what is the need of our target population? Because I feel often I go listen to people talk about work that they're doing wherever, and it's not really clear, like, is that just a convenience sample, or is that just a sort of a convenient strategy, or is it actual real need? And then I'm going to talk to you a little bit about what it means, for us to be designing a structural intervention. I have never done this kind of work, so we've really had to step back and sort of think about the process here. So a little bit about the plan, a little bit about the project team, a little bit about the data collection we're going to do, and then some thoughts we've had about what those intervention strategies may look like. Share with you some data and some next steps. And then, of course, if you have questions, just ask me as we go along. All right, so usually this picture gets people going. So there are lots of messages about HIV in Africa. I don't have a lot of slides on why HIV is a pressing problem in Africa, but I think most of you, particularly public health folks, are certainly aware that much of the HIV burden is in Africa. But there's lots of prevention messages, health promotion. Not all of them are evidence-based. So when we saw this, I don't know what we call this, painting, chart, poster, whatever, for the Africans to avoid morning sex. Just not clear why or where this came from. But bottom line, in Uganda, the prevalence of HIV is very high, much higher even in the Eastern African region. 3.7% of young adults are estimated to be HIV positive. And in the population that we will be working with specifically, more than 10% of youth 12 to 18. So notice I didn't present HIV here in rates, which is what we typically do because the numbers are relatively low. When we talk percentages, right, it goes to a whole different other domain. So what about alcohol? Typically, you probably have not heard about alcohol use in sub-Saharan Africa. I can say as an alcohol epidemiologist that I hadn't myself until a few years ago. A couple years ago, the WHO, who releases, cross-national and comparisons regularly, reported that Uganda actually had one of the world's highest per capita consumption of alcohol. Now, of course, you can measure alcohol use a number of different ways. You can look at overall consumption, like this slide, in liters of pure alcohol. You can look at heavy drinking. You can look at the percent of the populations who are drinker versus non-drinkers. So you can look at those from a number of different ways. But this particular slide, again, shows total alcohol consumption per inhabitant of Uganda, if you will. So that assumes everybody in the population. Uganda has, like many other countries in sub-Saharan Africa, lots of abstainers, people who don't drink at all. So what that means is that this number is sort of diluted among everybody. If you only looked at drinkers, they'd be drinking a lot more. There are a couple points to this slide, recorded versus unrecorded. Recorded drinking is that type of drinking, alcohol sales through regular stores and bars, those kind of settings. Unrecorded is when, in the US we call it moonshine. In the rest of the world they call it different things. But it's the type of alcohol that doesn't get recorded in the systems in terms of sales. So the recorded alcohol use in Uganda, at least until a few years, remains much higher than the regional average. And the unrecorded alcohol use seems to be increasing quite rapidly. So what happens when we put alcohol and HIV together, particularly among youth? Well, when we talk about the HIV part, it's widely recognized that the youth in sub-Saharan Africa is one of the most critical high-risk groups for HIV prevention and treatment. But one of the pieces that's not really been addressed among this group is the role of alcohol use in risky sex, in alcohol-related transmission, etc. And we know, of course, that adolescents who use alcohol are much more likely to be sexually active than non-drinkers, and those who drink heavily are less likely to use condoms, so they're more likely to have unprotected sexual intercourse. Now then there's another reason that what makes it particularly interesting and relevant for alcohol and HIV among youth in Kampala is that there's a tremendous amount of alcohol marketing. And that's hard sort of to appreciate because we live in a country in a setting where marketing is highly regulated. You cannot put alcohol ads and marketing material wherever you want. It has to be so far away from, schools. You can't put it on certain times or certain television shows. But in many other countries, the alcohol industry actually regulates itself. And the industry has seen sub-Saharan Africa as an emerging market where they're putting more resources, just like tobacco. So that's another thing that's contributing to increased rates of drinking. So questions so far? Okay. Oh.
On the stats you had about drinking, can you give us just some context, some comparison stats for the U.S. just to understand the scope a little bit? Even if it's not the liters or just...
Okay. Yeah, no, liters is a particularly difficult one. I wouldn't know liters. That's a good one. And I should know this on top of my head, but of course now I'm drawing a blank. I mean, drinking in the U.S. is very high. If we have a minute afterwards, I could go online and pull up. There's some beautiful charts.
No problem.
I don't think I have this part of this one, where the WHO really sort of showcases which parts of the world. So typically, in general, when we talk about drinking cultures, right, U.S. doesn't really come up, but typically we talk about Ireland, the UK, maybe Finland, Russia, some of the Eastern European bloc. But usually Africa is not really talked about. If you talk to the Australians, they sometimes also come up. But again, it's really tricky in how you operationalize the drinking measure. Drinking versus non-drinking, heavy drinking, non-drinking, liters, etc. But it's a very good point, and I'm sorry I can't address it better. I really should be able to.
Thank you, ma'am.
But in terms of alcohol marketing, this was one of the areas where we had great interest a couple years ago. And a few years back in 2011, we actually conducted a study to sort of as a first attempt to try to understand from the youth perspective what kind of exposure to alcohol marketing they had. So this wasn't a particularly sophisticated study. We did not go on measure marketing and posters and things like that, which we now have done since. But at that time, we really just did, sort of a very simple cross-sectional survey, asking youth themselves, do you see ads? What do you think about the ads and things like that? There's another marketing strategy that they have in this part of the world that we wouldn't think of here, especially when we think about youth under age 18. So in the U.S., drinking age is 21. In Uganda, as it is in most of the world, is 18. So what we thought was particularly interesting that the industry and vendors of alcohol use a strategy of giving free alcohol as a promotional strategy. That's something you would never see here for so many reasons, unless it is at a bar where people have already been carded and identified as over age 21. But there it's just much more common. So what we found in that particular paper was, and in that study was that for those youth who obtain free drinks, as part of this marketing strategy, they're much more likely to have problem drinking and problems associated with drinking and report being drunk more often, even when we look at things like age and sex and things like that. And the other part of that paper that was really interesting was that even though youth might have been told about the harms of alcohol, which is a strategy most of us tend to support and say, well, how about we just inform people of the risk? Shouldn't that make a difference? And in this case, it didn't. So it really shows us again that I'm not suggesting we don't do that at all, but I'm saying the recommendations we made was that you cannot do that in isolation. You need to have additional strategies. So we also were interested in HIV. And in that same study, we had asked about whether the youth themselves, age 14 to 24, knew that they had HIV. And so we were interested in sort of some just cross-sectional correlates of, what it might look like to have HIV, at least in this population. So what we found here was that there's a lot of hardship in terms of these youth having lost their parents. So if you look on the, do I have a pointer thing on this? So both parents said, for example, had a strong association with positive HIV status. Now this is cross-sectional data, of course, and we did not know when they became HIV positive. Of course, there's a chance that they could have been born with HIV, which we can't address. But the point here is that reporting self-disclosing HIV was associated with parents dead or having been deceased, drunkenness, and also expecting to die early. And this expecting to die early is sort of a marker, if you will, for hopelessness or sadness or fatalism, whatever we want to call it. But we were interested in the measure because if you are trying to work with a population, to sort of reduce health risk behaviors, if there's not a willingness to live, or if there's not an expectation that one will live, it's very much more difficult, obviously, to make a difference. And then linking it all together. So I've already shared with you that I'm interested in the sort of the intersection between alcohol, sexual engagement, and HIV transmission. So one of the pieces that we have to look at when we survey youth, this is also from the 2011 data, was whether they are drinking at the time of having sex, because we do know that when people drink at time of sex, they're just less likely to use condoms. And we were also interested, is it just the person themselves drinking, or is it the person and their partner? And what we found here, which was really intriguing, is that nearly 2/3 of couples having sex, if you will, both were drinking. And so that again shows that drinking is very common at the time of sex, which isn't that surprising, but it's helpful for us to know what that proportion actually is. So what have we found based on our 2011 data? Well, we have found that these youth have very high levels of social isolation. They're lonely. They come from fragmented family because many of their parents are deceased. We know that they have high levels of alcohol marketing exposure, which have not been documented ever before. We know that they have a higher prevalence of sexual intercourse but less condom use, and we would compare these experiences with those who go to school. I didn't say that, but the youth who live in the slums tend to be less school attending. They also have high levels of drunkenness, but drunkenness is also associated with HIV. We also find that there's a very high prevalence of drinking at time of sex, with both partner drinking, and a high levels of HIV overall, with nearly 11% self-disclosing that they have HIV. So that is sort of the preamble or the context for us trying to figure out, well, what can we do about this situation, primarily as it relates to early alcohol use and HIV. So we have gotten funding from the NIH to do this project, to create this intervention for youth who live in the slums who are ages 12 to 18. And part of this project, we are going to collect quantitative and qualitative data, and actually we're almost done with all of that, to really increase the knowledge base. What we had in 2011 was helpful, but not clearly enough for what we need. We also realized we need to integrate technology and more type of spatial analysis in data collection. These kids live in very urban areas in the slums. The slums and the structure of the slums are different than sort of just a regular urban setting. And there's some unique aspects to Kampala that is hard to translate if you don't take into consideration the spatial part of it. For example, they tend not to use maps the way we think of maps. They don't use street addresses the way we use street addresses. So there's a lot of layers to that. But part of the project was also to engage an international and interdisciplinary team, just because of the type of project this is. We are analyzing the data and seeking feedback from stakeholders, because again, in an international setting, it's very obviously critical that we're working with the people in Kampala. And then the idea is to use all these pieces to design this intervention, and this is the process that we're embarking on. And then, of course, it would be the finale would be to implement the intervention and evaluate it to see if we made a difference. So, is that a question?
Yes, ma'am. From looking at some of the literature, I noticed in sub-Saharan Africa, the concurrency, sexual concurrency is related to HIV. I was just wondering, do you know if alcoholism and sexual concurrency is related to each other? Do you know?
And I'm sorry, what's the last part?
Alcohol use and sexual concurrency.
Yeah.
Are they related in sub-Saharan Africa?
So what do you mean concurrency? Just
sexual concurrency, more than one partner at a certain time frame, a particular time frame.
Well, so I think that there are lots of layers to your question. It's a very good one, but there are layers to it. So it's about alcohol at time of sex. I mean, that's one that obviously contributes to not using condoms, for example. I mean, that's in the moment. That's right at the time where transmission might happen. But you can also look at patterns of alcohol use over time, right? You can say, people who drink heavily or who drink often or who get drunk a lot might have different partner selection, might have multiple partners. And so there's layers in which alcohol can contribute along the way. There's also, new research, this is less in my area, but there's also research that suggests that people who consume large quantities of alcohol actually impacts their immune system. So if you do get, HIV or you get semen or blood or something like that with HIV in it, that your body is just much less likely to fight it off. Again, not my area of research specifically, but just sort of to highlight that the role of alcohol in HIV transmission, there's multiple prongs. But typically we tend to narrow it down to the risky sex part. How sex is conducted, is condom involved, partner selection and things like that. So to step back a little bit so that you know and follow me along in terms of why are we doing a structural intervention and what does that mean? This is a framework, I don't even know if it has a name, I've looked for it, but it was developed by Scribner et al. And presented a couple years ago in the alcohol literature. And they really just wanted to highlight sort of an ecological framework or perspective, if you will, to HIV infection and how alcohol consumption can play a role. So building on what we just talked about. So if we look at the bottom of the graphic, tends to be like as epidemiologists or, behavioral scientist type people, it's very often that we look at individual characteristics, right? And then we look at alcohol use, and we look at high-risk sex, and then we look at HIV infection. So for pretty much any risk behavior, this is a model that we frequently use. So when we add to the social ecology, if you will, we start looking at, what happens at the interpersonal level with the people that they interact with. So for this particular topic, if we step up a little bit, and look at levels above the person, we talk about, well, what do their sexual networks look like? For example, in Uganda, the average man might have, multiple partners, multiple wives even. Each woman tends to have about 8 kids, and so the family networks can become very complex and large, as also the sexual networks and the peer networks become larger, although that's a little different in the youth that we work with. But anyway, networks and norms around sex become very important, right, in terms of the link between alcohol use and high-risk sexual behaviors. But we have the neighborhood alcohol environment. So what might be some neighborhood features in an environment that has to do with alcohol? What could they be? How could neighborhoods vary? What could vary at the neighborhood level with respect to alcohol? Some obvious ones. Yeah, access, exactly. How many stores are selling alcohol, and are they selling them, to anybody or people just minimum age? But we could also put marketing here. Are there restrictions for marketing? You can also say, well, how many people do you see drinking? Is there sort of a culture of drinking? When you drive to a new city, it's pretty clear when you look and say, well, this is the party district. There's just characteristics that we are drawn to or understand to be that. But then if we step up from the neighborhood and we look at, we can call it society, we can call it county or city, whichever level we're interested in, that could be about the policies. So when I mentioned about, say, living in Atlanta or Georgia or in the US, there are lots of restrictions on alcohol sales, pricing of alcohol, where alcohol can be sold, to whom it can be sold, and how it's marketed. In an environment like this in Kampala, there are some restrictions, but most of them aren't even followed. So I wouldn't call it a free-for-all necessarily, but we cannot impose sort of our American understanding of what this looked like in this setting. So anyway, so this schematic is really just pulling together that we need to consider multiple levels if we're going to impact this. Okay, so in order to do this, obviously we cannot be doing this from Georgia State alone. We need to have a team, and we have a community partner and collaborator. They're called the Uganda Youth Development Link, or UDEL for short. They're a relatively large NGO or non-government organization in Kampala. They have about 6 drop-in centers where the kids in the slums can go for services, get a snack, get vocational training, or just get counseling and support. They can also get clinic referrals and health screening, and they get referred for HIV, for example. But this NGO also serves as an advocate for youth, are very active in policy development and trying to push policies along. And they have great leadership in the executive director, who I have now known for a couple years. The team, the actual research team, if you will. So this is my project. I work with Mr. Kaziri in Kampala. We have one of the professors here in the School of Public Health as well, Dr. Laura Salazar, who's a community psychologist by training. We also have Dr. Darshan Dai, who is one of our faculty in geosciences in College of Arts and Sciences, and we have several master's and doctoral students involved in this project. We also have a couple of consultants who are part of the project but have different roles. We have faculty members from Makerere University in Kampala to provide statistical and local support. We had Dr. David Jernigan, who is the expert on alcohol marketing all over the world. We have Dr. Isidore Abot, who is an expert on alcohol use in Africa. We have Wim van Dalen, who does alcohol marketing research in Europe. And we have Anne Gamarova, who does all kinds of health campaigns and have worked with USAID and the US government to do all kinds of health promotion campaigns. And we have Josephine Okama, who represents another NGO who serves youth in the slums, so that we have appropriate perspectives. So, to the data collection projects, what were the pieces that we wanted to do? Well, we wanted to do environmental scans of alcohol marketing. I mentioned UDEL has 6 of these centers across the slums of Kampala, and we have looked at marketing around them to see what that looks like. We have also done a fairly large youth survey of youth 12 to 18 to get their experiences and perception primarily on alcohol, marketing, and high-risk sexual behaviors, but lots of other questions as well. We have done and are continuing to do youth focus groups to understand layers of the data based on the survey, and as we're thinking about intervention strategies, trying to figure out what we need to know from them. So for example, I'm going there with my team tomorrow, and the focus groups we're doing next week is really about connectivity. Could we, for example, access to youth through mobile phones? If they don't have mobile phone, would they be willing to have one? Could we follow them, ask them questions to see, if the intervention would be working? Trying to figure out sort of cost-effective and streamlined ways to do this project, but at a larger scale. But we're also involving other NGO leaders, so people who have other organizations that are involved in alcohol and policy development. So we did a survey of them. We had about 50 or 60 of them answer lots of questions about what they think the priorities should be, and if they wanted to deliver the implementation, to implement and deliver the intervention we're working on. And we're doing some focus groups with them next week to figure out, more specifically how they would suggest that we strategize and get this implementation and the design of the project done. So just to give you sort of a little highlight of what an environmental scan, what the data could look like. It's a little hard probably for you to see that this little red X in the middle, it might be hard to see, but that's one of the UDEL drop-in centers. So what we did simply, or what Sarah did for us, was to draw a 500-meter radius and then just draw this circle. Bless you. And then these are obviously roads, and so we had teams to walk up and down all the roads to see where there were alcohol marketing visible from the road. So this is one of my other students, Alicia, and you can see she has all kinds of gadgets hanging on her. There's like a little camera, there's a logger, there's what we call the Garmin. I don't know if you worked with those, but they take the GPS coordinates of where the marketing is, so that's how we can get to put them on a map. So that was one of the pilot projects we were doing, and now we're working to see what that looks like. But we're swimming in data on alcohol ads. So if any of you are ever interested in helping us do some analysis of what the ads and the contents and things like that, talk to Sarah or I, because we have so much stuff. We could never do it in a lifetime, I think, at this point. Although we can't think like that. We're going to do lots. So anyway, so that was one piece. But in terms of the cross-sectional study, which I think perhaps is the meat of the project, I mentioned 12 to 18 years of age. We did it a tablet administered, which actually streamlined, and we could ask lots of questions. We had a very high participation rate, which was very good, but we also have technical difficulties and lost data, which was not so good. But that's what happens when you work in the field. The survey we did was modeled from the Youth Risk Behavior Survey, which some of you may have known about. It's a biannual survey, has lots of questions on everything from violence to dietary thing, although we didn't pick the diet stuff. But it was modeled from previous work. So we were primarily interested in demographic characteristics, the family context, alcohol use, alcohol marketing, violence, suicidal behavior, sexual behaviors, STDs, and HIV. So what did we find? Well, of the people who took our survey, nearly half were boys, nearly half were under 16 years, so we did get a good distribution between 12 to 18 years of age. Many of them live in one room for sleeping. So again, these are large families. Most of these youth have many siblings, so the whole family use one room for sleeping every night. 1 in 5 have lived on the streets, meaning have not had sort of a stable shelter. 1 in 5 are orphans, meaning they have both parents deceased. We had a good distribution of Christian Catholic, Christian Other, and Muslim, which is something that we also want to look at in terms of patterns of alcohol use and marketing in the communities. In terms of sexual initiation and risk, we find that about half of them had ever had sex, so fairly sexually active. 42% had started before age 14, which also speaks to the fact that we need to start relatively early with prevention messages. More than a third do not use condoms with their partner in the past 3 months. And in a sample or in a population with about 10-11% HIV, you can see how quickly this will be exacerbated. And more importantly, 14% engage in what they consider commercial sex work, which is another obviously high-risk engagement. Yeah. Yeah, girls and boys. I mean, more girls than boys, but still both. So when we look at HIV-related concerns, like I mentioned, 11% know that they have HIV. This is probably an underestimate because not all of them have been tested. 2/3 say that they have been shown how to use a condom. That said, more than half did not use condom at time of first sex. Nearly half report having sex with 3 or more partners, and nearly 1 in 5 have been raped. So again, just to illustrate the high-risk environment, the vulnerability, and the victimization of these youth is really profound and disturbing. We talked a little bit about this a moment ago, about the prevalence of participation in partner drinking at time of sex. Here we just broke it out a little bit about drinking heavily and see if that made a difference. When we pull out drinking heavily, there are fewer who drink at time of sex, but still a substantial issue. Another topic that I'm particularly interested in is the time people start using alcohol, because from a prevention point of view, it's always better if we delay. That's the same issue in the US and in other parts of the world. And here we find that the normative age of starting to drink is really 15 to 16, which is very similar to what it is in the US. But that also means from a prevention point of view, we need to come in earlier than that, or we've missed the mark, if you will, because people have already converted to becoming drinkers. So what about drinking patterns and preferences? Well, 50% of the sample of those who drink a couple times a week. They get their alcohol from a friend. They drink with their friends. Only 1 in 5 find it hard to buy alcohol. So remember, these are 12 to 18-year-olds. So that means, the vast majority, 80% plus, easily buy alcohol, 1 in 4 prefer drinking alcohol in sachets. And the picture to your right here, I don't know if you can really see, these are bags of bags, if you will. These are boxes that distribute small bags of alcohol. So if you can imagine, if you were to go to a liquor store in Georgia, you see the glass bottles, right, with like your Smirnoffs and Baileys or whatever. But here, imagine like a Ziploc type bag that sell very, very strong alcohol that is sort of knockoff brands. They sell them very, very cheap, and this is a strategy, particularly in Islam, to promote purchase, because again, you can more easily purchase a sort of a single dose, if you will, although that would be stronger than a single serving by our standards. And about a third of them prefer locally made alcohol. So, there's alcohol available from all over the world in Kampala and Uganda, but there's also much locally made beer and spirits called Boraji. So when we ask the youth, from their own perspective, we have tons of questions about exposure to marketing in various ways. But to pick out just a couple ones, just to show you how they report to seeing alcohol or say actors drinking on TV, you're seeing specific alcohol brands on TV, magazine ads and promotion, if they just see ads walking around the community, billboards, whether they see a lot of people drinking. So it's just sort of just a snapshot of the alcohol environment that they're in. So anyway, so that's what we have to date. So what are the next steps? Well, we are completing recruitment and we're conducting focus groups. Like I said, we're going there tomorrow to do more work next week. We're considering redoing some of the environmental scans. The reason for that was not that we didn't do it and it didn't work out well. The problem is that we used the Udell Center as the hub for the community, and it turns out that's not necessarily where the kids hang out. So when we look at exposures, it would make more sense for us if we get a better sense for where the youth were hanging out. We're going to be repeating focus groups with youth, because whenever we sort of get to the next step, we realize that there are certain things we still don't have a good grasp of, and we need to go back and talk to the youth directly. We're still analyzing lots of data. We have done all these surveys and focus groups, so we're looking at that. So we're really about initiating now what this intervention should look like. We're talking about how do we message themes and how do we test the themes and what type of environment. One of the pieces I didn't share with you was that this population is also not very literate. So how do you do messaging in a way that, it's not like you can just take a campaign from the US or Europe and sort of say, put it in there. Not only does it need to be culturally relevant, but it also needs to speak to an audience, if you will, that may not speak English and may also not read very well. But we're talking about things about how to brand a campaign. We're talking about the intervention scope and intensity. For how long do we need to run an intervention? What are the costs? We also need to figure out, which structural levels we can actually impact. I mentioned a little bit earlier about the importance of policies, for example, but it's not clear whether these communities would be receptive to that. So that's another thing that we need to tease out. So targeting and working with the communities will be particularly important. And then, of course, we need to figure out how would we evaluate this intervention after it's been implemented. Well, one can say, well, if we're really about reducing HIV transmissions, do we actually screen and test all the youth, whether they have HIV? So there are logistical issues and costs with that. And then the question is, how much of a reduction could you actually see? So those are things that we're struggling with, if you will. And building partnerships is something that we do constantly. So some of the technical challenges practical challenges, we have encountered the technical difficulties. We lost a lot of data. I also highlighted briefly that working in Kampala presents challenges, not because it's far away, but because things are done very differently. They don't use maps like we use maps, and so when we talk about the geospatial part of it, we have to be very creative and figure out what makes more sense in that environment. The other challenge we're now facing is we have all these data and we have all these pieces. So how do you actually streamline and integrate it and synthesize it in a way that is most meaningful? And then these youth have very unique needs. Again, low level of literacy, there are huge language barriers, and they tend to be very isolated and fragmented. So given that many also come from broken families and families where the biological parents have deceased, you cannot really incorporate a parenting function or a parenting component to these interventions that you would, for example, in another community. And then again, we are not at all certain in terms of the willingness of the communities to say reduce giving free drinks to the youth because, that somebody's aunt who's working there who needs that money to send her kids to school. And if we start, what does that mean for them professionally and for sustaining their families? The other conceptual challenges we're facing is that we're focusing both on alcohol initiation and alcohol-related HIV transmission. And while the two goes hand in hand, it might be for this type of project that we're actually better off splitting them up. So that's something that we're considering too. The other thing is, how do we apply evidence-based prevention strategies from other settings, and can you? So that's something that we're considering. And then, of course, there's very limited research on structural interventions for alcohol and HIV. For alcohol, there is a ton of information, and that's why a country like the US have made such great progress in terms of policy implementation. But for HIV, not so much. And then, of course, our final and ultimate challenge is how do we create a compelling case, for funding this work in Africa with, US government tax money. What is the implications and benefit to the US? So that's something that we also need to be clearly articulating. So I shared with this earlier, so lots of needs among this youth. We're very compelled to continue working with them. And we're also, I highlighted this one part of the project, which is the alcohol and HIV part. But we're doing other projects related to trying to figure out how to implement screening. We also have people on the team interested in looking at violence prevention and gender-based violence, building literacy. So there's a whole number of other topics, to address some of the needs that they have. We have written lots about whether it's suicide ideation or whether it's even access to mobile phones. We have talked about disparities in this population compared to school-attending youth. We have written on violence victimization and perpetration. So while I highlight that this project is about alcohol and HIV, we certainly have other measures. And so this is my little plug to all of you who might be working on a thesis or be looking for data in the future to work with. So finally, I was just going to say a note about why it's important for collaboration, because I think we often miss that point. It has been tremendously rewarding to work with the Kampala team and the Uganda Youth Development Link. I've worked with them for many years at this point. But the reason why they partner with us and with Georgia State is because it's a mutually beneficial partnership. And we're not just doing the work and run away, and we're not helping them with what they need. So from their perspective, we have provided research data so that they can better document the need of these youth, which helps them for fundraising and help them organize their programs, that they have ongoing. Also, as part of doing all these research projects, we've actually trained some 50 of their staff in all kinds of research methodology, data collection, embracing new technology, whether it's tablets or garments, etc. We've obviously written papers, and they're typically co-authors in all these papers, which means that they get recognition in the scientific community. We have several of our students at Georgia State End who have used these data for thesis or presentation. And you see myself and two of my students. This was actually a day we were leaving in June, and we picked up the newspaper and found out that a presentation we had had the day before was all over the newspaper, which we almost missed. But it gave them great exposure and great visibility, and it really is very rewarding when the research is needed and used. So the media visibility is something that is very important. But I've also, through this collaboration, found other collaborators and really expanded my network. For example, I mentioned that Rogers Kasiri, who I work with, is a fantastic collaborator. Well, after we're done with the research part next week, he and I are flying to Malawi, another sub-Saharan African country, to see about starting a project there. So we're growing. So there's always new opportunities. So if you put in the effort for good collaborative relationships, and broadly defined, I think all kinds of things can happen, good things. So that's it. Questions? Yes?
I have just a methods question. Can you talk through some of the challenges and successes going through IRB with international research here?
Oh, so the GSU IRB has not been particularly difficult at all. And I think that's in part because, this type of studies that we were doing are cross-sectional, anonymous. while you could say that there was some sensitive data for this kind of population, there wasn't anything that would be more sensitive than that they experienced in their daily life, which is one of the criteria that they used. The tricky thing was for this kind of population, we had waivers of parental consent because there's so few of them that would have parents. It was unclear of who would be the most appropriate person to give us access to them. But using some language from Uganda and their ethic review board was that there's a statement, I'm not sure if I'm getting it correct now, but something about youth who cater to their own livelihood, with some other criteria, that they're waiving that. So the GSU RB actually allowed us to waive parental consent. And it was also asserted that the Uganda Youth Development Link, who these kids come to voluntarily for training and counseling, are in a probably better place to support the needs and well-being of these youth than whatever their home situation may be. So that could be a potential tricky thing, but we navigated that. But the trickier part was the Uganda National Science Board. So, so we had to get approval at GSU, but we also had to get approval on the other countryside. And it wasn't like they had questions about our proposal or required changes. They pretty much deferred to GSU because GSU, obviously, we have an accredited RB. But it's just a timeliness or lack thereof. And I can't remember how many months and months and months it took. It finally took me flying over there and walking into the office with Rogers and greeting them and insisting, and the day after I got the letter. And that was about a couple weeks before we were scheduled to start the project. And so I had to make an extra trip in February, and we did the project in March. And otherwise, I might not still have had approval. So it just sits in a big pile on somebody's desk, and they're all overworked and underpaid, and you just got to grease the wheels. Yeah. Any other questions? Yes?
I was going to ask you to maybe expand a little bit more on community participation. You mentioned the recruited youth as counselors. And do they play a greater role in terms of advising or providing feedback on research or methods and so forth?
So very good question. We didn't recruit necessarily from the community, but so UDEL, this Uganda Youth Development Link, the organization, they hire what they call peer educators. So these are people typically that have grown up in the communities that they serve. Some of them have a bachelor's or master's degree in social work or a related topic. But again, they come from the community, they work with the youth. So when we do focus groups and when we do surveys, they tend to be the one who interact with the youth and talk to the youth. And they have always been very instrumental when we talk to them. So when we do training, as we're going to be going and doing on Monday, and they provide input, and a lot of times they give us feedback before we go there, but it's typically not until we sit down and we go through all the items and they tell us, well, this is not how you would ask it, or this is just not worded correctly, or I think we should use this strategy for recruitment instead. And I think that that's a critically important role, because when we did the first project in 2011, we didn't have those layers in place because I didn't know what I was getting myself into necessarily. And so we did lots of mistakes. It wasn't anything, it was no adverse events, and it was nothing bad. It was just, it wasn't as thoughtful as it could have been, and there were some missed opportunities that I think you just learn with experience and working with people and the environment that you're in. But I think the community based participatory approach is something that we really want to incorporate for this larger intervention that will be critical, because that's all about the community. And if we don't get their buy-in and they don't welcome us into their communities, then there's no point. So very good question. Anything else? Sarah?
Can you go into how the different kinds of UDEL centers work? Because there's some that are residential, some where the kids work, and how could interventions be targeted to the different types?
So good point, because Sarah knows more about this. So I really just made reference to the drop-in centers. So the drop-in centers work in a way that, if you're in the neighborhood and you're feeling bored or you don't know what you want to do one day, you can just go there and hang out, if you will. There's nothing fancy. It's like a hole in the wall. But people sit and they mingle. But in addition to that, they have the vocational training. So for the women, for example, it tend to be very much of the hair braiding. It tends to be some cooking for the guys. It's very gender segregated. They're trying to overcome that, but typically the ladies select the hairdressing and the guys select the metalwork, computer classes, etc. But in addition to these drop-in centers that are scattered across the slums, They also have a residential facility where youth stays for about 6 months to a year, depending. And these tend to be youth who have been, sexually trafficked, or they've been orphaned, and there's just no clear path for them or a clear family environment for them. So they get more intensive counseling because, again, it's residential, and they also get vocational training so that they get a certificate when they graduate with, some kind of diploma to certify that they have some skills and be easier for them to get employed and make a living. So the interventions that we're doing, this is intended for the community, so the people who are out and about exposed to marketing and who are buying alcohol. There are lots of intervention opportunities for the residential treatment as well, but since I'm not a clinician, I tend to do more of the community public health rather than the residential one. But I think that there are some strategies that we can incorporate with them as well. It was a very good suggestion.